Good to be here and spend some time tonight talking about a few things that I enjoy taking care of, and presumably are things that the folks watching here tonight are interested in learning more about. Thanks for spending time with us tonight here. It's a nice night outside, so maybe some of you are outside watching this, but thanks for spending some time inside tonight. So main things we're going to focus on tonight are erectile dysfunction and stress urinary incontinence. So, the nice thing I tell a lot of people about these conditions, fortunately, they're not life-threatening. You are not generally going to die from these two things, but they can certainly be life-altering. And, you have maybe a standard that you're used to and have had for your whole life. And then some of these conditions we're going to talk about tonight have impacted both of these things. The good news is we have a lot of great options for helping treat both of these conditions. So we're going to start off talking about erectile dysfunction. And there's a QR code that you can scan here with your phone, and you can just hold it up to the screen and do that. And there's also a website linked on here. And a lot of this information, for any of you who've seen me in the office or have my card, there's a QR code on my card that will take you to a site that has these videos on it as well. Or if you, for some reason, lose this site, can't figure it out, write it down wrong, whatever, you can look me up on the practice website, urologynashville.com, and this same hard series videos are linked on that page there, so you can find them there as well. So I'm a prosthetic and reconstructive urologist. I've been in practice, I guess 11 years now. I was previously at the University of Alabama, Birmingham, and was an associate professor there. Moved back home to Tennessee a few years ago, and have been with Urology Associates for a few years. Did my medical school at University of Tennessee in Memphis, and then moved over to North Carolina for residency and fellowship. And my training really specialized in treating both of these conditions, and have done that ever since I started practice. So we're going to kick off starting with erectile dysfunction. So what is erectile dysfunction? I think for many of you, it's obvious. It's the inability to achieve or maintain an erection that's firm enough to perform sexual intercourse. So I think the good news, I think, about ED these days is people are talking about it a little bit more. We hear about it more. There's social media. There's things that maybe aren't as taboo as they used to be. And so the good news is this is talked about more. And for that reason, I think it's less of a taboo thing to talk about. And you see these studies, some of which were actually performed back in the 90s. People have been afraid to talk about their erectile dysfunction. But in fact, if you look at, they did a big study in Framingham, Massachusetts, where we had a lot of information about a lot of prevalence of diseases in men and women. And what they found was actually in about 40% of 40-year-old men had some form of erectile dysfunction. Those numbers tended to go up as men got older. So, clearly you can see, more than half of men, in some cases, when you get up into the higher decades, it's well over half of men that suffer from erectile dysfunction. So there are a lot of physiologic processes involved in an erection and getting hard. So, first step is arousal. And then what happens is there are nerve signals that are sent through nerves that are around the penis. What this causes is a release of some chemicals that relax the blood vessels and smooth muscle that are there. And that allows blood to flow in. That blood flows into these corporal bodies that are in the shaft. And as those things fill up with blood, they compress these blue veins that are around it, and that squashes those veins so the blood can't drain out. So the blood will come in and not drain out. Anything that impacts that process can cause folks to have erectile dysfunction. So damage to those nerves, damage to those arteries, damage to those veins, damage to these corporal bodies would be your classic things that would cause people to have trouble with erectile dysfunction. So lots of different things can do it. Risk factors that can contribute to erectile dysfunction. Obviously, older age can do it. Smoking, because it damages blood vessels. Diabetes damages both blood vessels and nerves. high blood pressure and other vascular conditions, the things that we think about that we know, I tell guys, if it's bad for your heart, it's bad for your penis. High cholesterol, smoking, high blood pressure, diabetes, these things that we know, lead to heart attacks. They're the same things that lead to erectile dysfunction. And so the biggest things we're going to see in the office are folks who have vascular conditions. So that's some things involving blood vessels, high blood pressure being the big thing. And then diabetes is another big cause. And then we'll see it, in our world from pelvic surgery and pelvic trauma, sometimes caused by us. The important thing, I think to recognize about erectile dysfunction, it's not just a physical problem, but it can also be have a significant psychological impact on folks. And it's been shown to have associations with anxiety and depression, low self-esteem and self-confidence, and decreased quality of life in men. Again, the good news is we've got some things we'll talk about tonight that we can hopefully help improve those things in folks. Lots of different ways that we can treat ED, pills, vacuums, injections, implants. If you look at some of the studies on implants, which we'll talk about a little bit later, and some of the other things as well, but there have been a lot of different surveys done on penile implants and how they help people. I think the main thing that you see in these surveys that they do, both of patients and their partners, are very high satisfaction rates with the device. So you're looking, mid to high 90s. And I may even be a little conservative sometimes in what I tell people, but it's not only the patients that are reporting this, it's partners that have reported rates this high, and then also people telling it that they would recommend it, to their friend. One of the big causes of erectile dysfunction is diabetes. So how does diabetes contribute to erectile dysfunction? Well, we mentioned before, nerves and arteries are key to it, and diabetes impacts both of those things. So if you look at the condition of diabetes itself, half of men with diabetes are going to have trouble with erections, especially those of you that have had type 1 diabetes. Sometimes you're diagnosed at a very young age. No matter how well you control your glucose and insulin, that decades of, diabetes can lead to erectile dysfunction. And what we've also seen are that men who have diabetes can sometimes be less responsive to the things like Viagra, Cialis, Levitra, those oral therapies, not only because it's blood vessels being damaged, but because it's nerves being damaged as well. And unfortunately, because guys sometimes don't like to go to the doctor, I've actually had quite a few people in my practice that I've diagnosed with diabetes who didn't know they have it, who come in with erectile dysfunction. Guys in their 40s don't go to the doctor, never have. They're having trouble with erections. And hey, guess what? Your glucose is out of control. Your blood pressure is out of control. These things can, be big contributors to it. So how does diabetes impact it? Well, like I mentioned, it's nerve damage, it's blood vessel damage. So diabetes and elevated blood sugars will cause damage to these nerves, and it will cause inflammation and damage in these blood vessels. If you can't get the nerve signal to the penis for erections, then you're not going to get the blood vessels relaxed. If the blood vessels aren't relaxing, you're not going to fill those corporal bodies up with the blood that then squeezes the veins. So anything that impacts those, and in this case, diabetes kind of being a double whammy, it will limit your risk. And oftentimes it's these little small blood vessels that we see are what get damaged first in diabetes. And, for those of you with it, another classic condition you see with diabetes is peripheral neuropathy. People who have numbness or tingling in their fingers or toes. Well, this is another thing that can get that same damage in the nerves. We see that not only does diabetes do it, but the length, like I mentioned before, the length of time that you've had diabetes, the worse that your diabetes is controlled. Some of the medications that folks take to help with their diabetes treatment can contribute to it. And again, advancing age pretty much compounds most of the things that we deal with in our world of urology. How about heart disease? So the unfortunate thing about erectile dysfunction and heart disease is that erectile dysfunction can actually be a predictor of future heart-related events. We'll have a little slide that kind of shows why. But again, like I mentioned earlier, anything that's bad for your heart is bad for your penis. It's all about small blood vessels. And as these small blood vessels get damaged, they don't work right. Your coronary artery gets clogged by plaque, from cholesterol, high blood pressure, smoking. It's not just happening in your heart. It's happening in your kidneys. It's happening in your brain. It leads to stroke. It's happening in your penis, leads to erectile dysfunction. And so we actually see in some of these younger guys, and I see them, hey, you're having trouble with erections now. You need to make sure you're checking in with your primary care doc and getting your EKG checked, and that we're not missing something that's going to be a little more sinister, here in the next few years. And it's been shown that erectile dysfunction can be a predictor of future heart-related events, even in as short a time as a couple of years. And this is a diagram here that kind of helps show that. This is the typical diameter of a penile artery, 1 to 2 millimeters. This is your coronary artery, 3 to 4 millimeters. Your femoral artery in your leg, your carotid artery in your neck, much bigger blood vessels. But you can see somebody who's walking in, having a heart attack because this artery is clogging. What do you think's going on in this artery? So it's the same disease process, and it's starting. It's potentially going to have an impact sooner because of anatomically more narrow artery. So the best ways that guys can reduce risk, it's probably something you hear from a lot of your doctors, and it's something I tell a lot of people, but the easiest things that you can do are eat right and exercise. So, there's not necessarily a specific diet I tell people. People hear about, I think more popular these days are these carnivore diets and things like that, but it's the diets that we have actual studies on, many of which you can find at the American Heart Association website, but DASH diets, Mediterranean diets, these diets have been shown to improve erectile dysfunction, among other things. As far as physical activity goes, you want to get aerobic exercise. So while weightlifting, is good for a lot of things, bone health, muscle strength, reducing falls, it's aerobic exercise that's good for a lot of these vascular conditions. So your heart health, erectile function, it's getting your heart rate up, whether it's running, really fast walking, biking, that kind of stuff. Losing weight is obviously going to be helpful there. And again, avoiding those things that we all know are bad for us, smoking, alcohol, illegal drugs, those are going to be the stuff that impacts blood vessels as well. And of course, stress is a pro-inflammatory condition. When we're stressed out and we're really revving up these pro-inflammatory factors in our body. So things that we can do to help reduce our stress can be helpful, again, not only for our erectile dysfunction, but other conditions. About low testosterone. So our American Urological Association guidelines recommend screening for low testosterone in men who have erectile dysfunction. And you need testosterone to help have an erection. There are a lot of things that can make your testosterone be low. There is no magic number for what a guy's testosterone should be. But the things that we see that contribute to a low testosterone are, again, age, obesity, again, diabetes, sleep apnea, which I think a lot of men have undiagnosed, and then chronic medical conditions impacting the kidney or liver. HIV and AIDS have also been associated with low testosterone. So testosterone impacts a lot of things. Main things I think I see when people come in complaining about it, or wanting to be checked out to see if they have a low testosterone, are going to be decreased sex drive, trouble with erections, decrease in their muscle strength or mass, or just kind of a general feeling of fatigue. It can contribute to a lot of these things. Replacing testosterone hasn't necessarily been shown to improve all of these things, but these are some of the things, if you are having symptoms of these, might be worth getting your testosterone checked. And because sometimes we can find, hey, maybe you were doing so-so with pills. Turns out you have low testosterone. Get your testosterone repleted through whatever therapy that may be, and we can improve your ability to respond to that drug. So lots of different ways to get testosterone: injections, medications, patches, gels. But sometimes that little extra bit of testosterone, because it was low, will help your body respond to those pills better. Many of you tonight may have been through prostate cancer treatment, and both of these conditions are significant complications we see from prostate cancer treatment. So my fellowship was actually in genitourinary cancer survivorship. So it was dealing with all of the complications of cancer in the pelvis, and not just prostate, but obviously prostate is a big one we deal with. Even when your surgeon does a nerve-sparing procedure, we see up to a year of time before men recover to generally where they're going to be in the long run. Now, there are some studies which say it could even be up to 4 years, that there is a small percentage of men who can see some increase in their erectile dysfunction as time goes by. But generally speaking, where you're at about a year after surgery is where you're going to be for the long run. And sometimes when it comes to treatment post prostate cancer, we may think about treatment options a little bit different here. But for those of you who are maybe potentially going to go through it, or have already been through it, your prostate's surgically removed. It sits between your bladder and your urethra. We stitch you back up. These nerves that go to your erection run immediately beside the prostate. And so we have to carefully peel those off in order to preserve them. In some cases, if you have a really bad prostate cancer, we may not really preserve those nerves very much because we're worried about leaving cancer behind. And those men, your rate of having erectile dysfunction is going to be significantly higher than a man who undergoes a nerve-sparing procedure. If you look at the literature on it, I generally would tell people about 2/3 of men will recover their erections where they were before surgery, but that may require at least pills now. And it depends really on your, two of the big factors are your age and the quality of your erections before surgery. If you're having trouble with erections before surgery, I assure you they're not going to be better afterwards. And most likely you're going to be worse off than somebody who had a perfect erection before surgery. Generally, what you see too with radiation is a slightly different time course, but they end up with a very similar rate of erectile dysfunction. So for those of you who had radiation or maybe thinking about radiation, the curve is slightly different with surgery. Your erections are down low right afterwards. They tend to get better as time goes by and then level out. With radiation, it's the opposite. Your erections are, maybe okay at first, and then they tend to drop off as time goes by. If you look at the big long-term studies, they generally settle out at the same rate of being a problem, though. The time course is different, but the time down the road, the rates are going to be very similar. Another condition that I deal with a lot, this is that bent carrot commercial that maybe some of you have seen on TV, and men didn't think that this was even a thing, but is Peyronie's disease. And so Peyronie's disease, this isn't that blood vessel or vein or nerve thing. This is that actual corporal body. So people will develop scarring in that tube that gets erect when you have an erection. It's a non-cancerous benign process. Many times we don't figure out exactly why some men get it. But what happens here, and we think it impacts the ability of those veins to be compressed or squeezed off. So it can cause not only curvature, but trouble with erections in that the blood can get in, but because there's a hard scar there, it doesn't stretch out like it should. And so those veins don't get compressed, and there's a lot of leakage of the blood out. So people can't get or maintain that erection because of what's called venous leak. So that blood is leaking out. So Peyronie's disease, unfortunately, there's not really any good oral medications for it. We might give something for somebody who's having some pain in that acute period right after it started, but there's not really any great oral option. We do sometimes do injection therapies that can help break up that scar tissue, and that's something that we do in the office regularly for that. The trouble there is that we don't have a lot of literature that says it improves your erectile function. We have data that says it can improve your curvature, but I don't have a lot of good stuff that says it makes your ED better once we get that fixed. In some cases, people aren't candidates for those injections or don't want injections, then we might do surgery. In cases where people have bad erections and bad curvature or bad Peyronie's disease, really it ends up being your best option is a penile implant because it'll correct both of the problems at the same time, rather than the surgery itself, just to correct the curvature and doesn't do anything for your erection. We haven't necessarily made you any better. So penile implants, again, another option for it. it tends to be the go-to, I'd say, if you have a really bad curve and really bad erections. If you have bad curve, but your erections are preserved, a lot of times we'll try some other stuff before we get to an implant itself. So slight transition here. I'm going to talk a little bit about incontinence now, and then we'll talk a little bit more about the treatment options for both of these things. But again, here's another QR code you can scan. Again, if you forget this site or don't have time to write it down, then it's again linked if you just look me up on the practice website. Okay, so stress incontinence. What's stress incontinence? This is leakage that happens kind of like what it sounds when you're doing stressful things. So coughing, laughing, sneezing, heavy activity, picking up stuff. This is stress incontinence. The other kind of continence is urge incontinence, or more along the lines of an overactive bladder. This is, I'm getting that urge and I can't quite make it to the bathroom in time and I start to leak a little bit. That is a different problem than what we're talking about now. We're talking about stress incontinence, which is cough, laugh, sneeze kind of leakage. This is generally going to happen in those men after a cancer treatment, perhaps some sort of prostate procedure done not for cancer, maybe for an enlarged non-cancerous prostate, or the other thing we might see for trauma. So anybody who's had a bad car accident, maybe a very bad pelvic fracture, and has disrupted their sphincter muscles and the things that help hold their urine in. This, unfortunately, probably I would say is the thing that I have a lot of men coming, initially kind of right after prostate cancer treatment or prostate. This is going to be the thing that's going to bother them more right off the bat. And on some of these studies that you look at, it's up to about 16% of men will have a long-term bother by this. And there was a big study actually done at Vanderbilt called the Caesar study, where they followed over 2,000 men after prostate cancer treatment, looking at the difference between surgery and radiation. And those rates were right around 14% in that study of men who had long-term bothersome urinary incontinence. So it's not, you are not alone if you're out there dealing with this. Why does it happen? Well, it's the same structures that we damage when we take out a prostate that go to the erection, those nerves. Your prostate is one of the sphincter muscles that helps hold the urine in a guy. We're lucky in the sense that we really have two of them, being that prostate, and then there's a sphincter muscle right below the prostate here. This is the one that, hey, you're in the bathroom and you got to cut your stream off for some reason. There's an emergency and you got to run out. That's this sphincter muscle. That's really what you're left with after a prostatectomy. So depending on how things heal up there, will depend on how well your continence is afterwards. And prostatectomies are interesting surgeries because you feel like you do the same surgery on two guys and one guy will be really leaky and the other guy's not. So there are a lot of different factors that we don't fully understand that cause this. But essentially, we cut out one when we do a radical prostatectomy. You're left with one. If that's not working that great afterwards, you're going to be leaky. So not only does surgery do it, like I mentioned, but we see it in radiation as well, or anything that can affect your sphincter function. So again, sometimes trauma can do it. I see it after pelvic surgery, say for colorectal cancer. So people who've had to have big operations to say remove their rectum or colon, that can contribute. And then occasionally we'll see folks after BPH or non-cancer surgery or some sort of other urethral surgery have urinary incontinence because of damage to this complex of muscles that helps hold urine in. As you can imagine, and those of you who are dealing with it, I mean, this can be a significant impact on people's quality of life. The number of people who don't do what they want to do because of this is really sad. And people coming in saying, I go to church and that's it. I don't go out and, see my friends because I'm worried about leaking. I only wear dark colored pants. I don't wear light colored pants. I go on vacation and I pack an extra suitcase of pads because of how many they're going through. This is, I see frustration sometimes on the end of folks from that. And then I also see folks, oh, we've corrected their problem and they're frustrated. Why didn't anybody tell me we had this problem? We had this thing that we could do to fix this 4 years ago. And so I'm glad y'all are here to be able to hear about it, because if you're out here suffering with this, I assure you, these are some of my favorite procedures to do because of how much they improve people's quality of life. So if you look at prostate cancer, again, being the big cause of stress urinary incontinence, there's about 90,000 radical prostatectomies. And again, depending on the study you look at, 10-ish% of people. So, you're looking at 9,000 people every year who are dealing with bothersome, leakage after their treatment. And we've got some really good options that can help improve that. Okay, so I'm going to transition a little bit now into the options for both of these things. So we'll switch back a little bit to erectile dysfunction, and then we'll move on to the incontinence. So erectile dysfunction, definitely not just treated by urologists. See plenty of internal medicine docs, family medicine docs who treat this. Once it gets, I'd say, beyond the basics, oftentimes of pills, it tends to make their way to us. But it's not just us who treats it. So if you have a primary care internal medicine doctor you have a good relationship with, certainly can always start there. Those of us who do this for a living, maybe have a little extra things that we know that can be helpful, or things that we can try that people who don't do it regularly can, that we can offer. And then folks like me and some others in our practice who are prosthetic urologists, we specialize in the operations as well that help treat erectile dysfunction and stress urinary incontinence for that matter. So again, big things we talked about, besides eating right and exercising, the main options I'd say that are out there today are the oral medications. So your Viagra, Cialis's, Levitras, Avanafils or Stendras, some of the dissolvable ones off your tongue. You can get these online now. Those are common. Vacuum erection devices. These I'd probably say I use them. They're probably not one of the most common things that I have men use because they're a little more cumbersome for folks to use. They can be good if you're post-prostatectomy, or say you've had a penile implant in the past and it had to come out for some reason. Vacuum erection devices can actually be quite helpful in if you've had an implant removed, for stretching the penis out and getting you ready for another one. If you're post-prostatectomy, using a vacuum erection device can be helpful for getting blood flowing in, and then we think potentially helping with some length or stretching of the penis, which can sometimes be an issue for guys after prostatectomy. Injections are probably the thing that we tend to go to oftentimes after pills have stopped working. These are medications that we teach you how to use, that you can inject directly into that corporal body, that shaft part that fills up with the blood. And nice thing about those, it's another option that's on the table. I'd say have quite a good amount of men who use those. But we oftentimes see people get tired of doing the injections. You got to keep the medication frozen. You have to go to the pharmacy to get it. It's a little not spontaneous, if you will. So we oftentimes see people burn out from that, if you will. And then there's penile implants, which we'll talk about as well. These are surgically implanted devices that help mimic the natural erection that men get, and are another option. Really anywhere along the spectrum. You don't have to go in an order from left to right here, from medications to implants. You can do it really in any order. So again, big things that we talk about are healthy lifestyle changes that can help with erectile dysfunction. For those of you who are concerned about a psychogenic component to your erectile dysfunction, psychotherapy can be helpful. We have some relationships with some therapists that we send men to. Oftentimes can be a good thing to bring a partner to as well. So if that's something that you think is a component, reach out to your urologist, whether it's me or someone else in the group. We have folks that we can make referrals to. Okay, so how about the pills? How do they work? They act on recall I mentioned earlier that there are some chemicals that are released that allow those muscles to relax, that let the blood flow in. Well, these things essentially help stimulate that. They help something called nitric oxide, which is released in the penis and allows these blood vessels to relax. They improve that nitric oxide stimulation and let the blood flow in. So, great thing about these, they're a pill. You're not injecting yourself. You don't have to have a surgery. Certainly common side effects that we see are headache or facial flushing, very, very common in men who first start taking these. They tend to get better as time goes by. Um, I'll sometimes see men eventually not respond to these. You also have to time it right. You can't just take it 3 seconds before you're ready to use it. You have to take it usually 30 to 60 minutes before you're ready, before these pills will kick in. And there are certain conditions where it's not good to use these medications. For the most part, you've got to have an unhealthy enough heart to be taking nitrates where we might say, hey, this medicine probably isn't for you. Vacuum erection devices, like I mentioned, these work differently. It's just like what the picture looks like. It's a literal pump you slide over the penis. You either have a battery powered or a hand powered pump on the end that will create a vacuum in it and then suck the blood into the penis. You then put a band around the base of the penis to hold that blood flow in. What you can kind of see here, and this is purposeful, is that sometimes the complaints that people might have would be that the penis gets a little bit cold or blue or numb because you've got this rubber band around the base of the penis. People also complain about a little bit of hinging, where this band goes around there. So rather than, your penis is normally attached into your pubic bone down in your pelvis. So now all of a sudden the fulcrum is further out. And so people notice that it's a lot more wobbly than they're used to. So I would say this is probably a little lower on my list of options that I have men that use regularly. More often than not, they said, yeah, I tried it and it didn't work. But it is good for certain things, like I mentioned, maybe post-prostatectomy, or if you're looking at, say, getting another implant put in. Injection therapy, as I mentioned, this is essentially bypassing all of the things that go wrong, with blood flow and nerves. So let's just get the medicine straight into that corporal body. I would say in post-prostatectomy, this can also be a very good option for men because they generally don't have a blood flow problem. You have a nerve problem because those nerves got injured and the nerves aren't sending the signal. So this can oftentimes, some of the people that you see the best responses of this medication in can be patients who have nerve-related reasons to have trouble with their erections. So diabetics, post-prostatectomy, or folks with spinal cord injury, these can be good options. Main downside that say you've got to inject yourself every time you want to have intercourse. You got to go to the compounding pharmacy to get the medication. These are generally, I can't say that I've ever seen them covered by insurance. So you're usually paying out of pocket for them. And, big complaint I think you hear from people is the lack of spontaneity. Time is right. Well, let me go to the freezer and get my medication and inject myself. That being said, viable option that I have, a lot of people that we do this on. Penile implant, last but not least. And again, like I mentioned, there's not an order. You don't have to try everything, before you get to a surgery. But what a penile implant is it's a device that's inserted into the penis. We usually make an incision either on top of the scrotum or just above the penis. And this is essentially a saltwater or saline filled implant that's replacing those corporal bodies, or at least the blood flow into them. And so the nice thing about them is that it's sort of ready whenever you want it to be ready. It's more spontaneous. You're not worried, hey, I got to go get my injection. I got to go take my pill. The time's not right, etc. And so the nice thing about that is that it's really there when you're ready for it to be there. And like we mentioned before, the satisfaction rates for this are very high. I mean, you're looking at it here again, 97% satisfaction rates in some surveys for this device. So there are a couple of different implant options. By far, the most common thing that we do is going to be one of these versions on the left here, the AMS 700. So this is a 3-piece device. So these are the cylinders that go in the shaft that fill with blood. This is a small pump that goes in the scrotum, kind of like a little third testicle. Everything is on the inside. None of this can be seen by anyone. And this is the part that you pump up when you want to fill these up. The salt water is contained in this little reservoir that goes in the groin area. And so we implant all of this, and this is, how we achieve the erection. The AMS device now has a newer pump called the Tenaceo pump, which is a little easier to pump for a lot of people. So this is kind of the latest iteration of the implant. And again, works the same way, though, as the traditional momentary squeeze pumps. Tactra is a malleable device. So what this is rather than, you can see this is just 2 cylinders and that's it. There's no pump, there's no reservoir. There's certain reasons that we might do this, but I would say for the average person coming in who's maybe failed the other things, we're doing one of these 3-piece inflatable kind. This is going to be in more unique circumstances. What's nice about the AMS 700 device, any implant you put in the body, whether it's a hip, a knee, a heart valve, a penile implant, where our biggest fear really is infection, because once infection happens, it's darn near impossible to cure it or treat it without having to remove whatever that implant is. So the nice thing about these AMS devices, they're actually encoded in antibiotic that's called inhibizone. And it's been shown really to reduce the infection rates in these devices, so much so that we used to worry about infection because infections happen more commonly than these things breaking. Nowadays, much less concerned about infection. It's more like, hey, it's been 15 years that you've had this thing, has it finally stopped working and you need a new one now? So it's nice to not have to have as much fear of infection. We still do lots of things when we're doing an operating, when we're in the operating room to try to prevent that. But what's great about the 3-piece device as well, it's going to be, it's compared to that Tactra device you saw, this is more likely to mimic your natural erection, not only when you're erect, but also when you're flaccid. So it has a much more normal appearance to it. That Tactra device is much more like a Gumby. It's just kind of bend wherever you want, but it's not really ever getting softer. And this device has been around for over 50 years. As you can see, over 500,000 devices, put in. So it's got a really good long track record of success. So this right here is an animated video of how the implant works and how it functions. And again, what it'll show here is really just the movement of the fluid from the reservoir in the groin area into the cylinders. So again, this up here is holding the salt water. You squeeze this pump in the scrotum and it'll draw that salt water through this tubing into the cylinders. And so most of the time we can get this in through one incision, not common to have to use a second incision. So we get it all in through one incision despite having 3 parts. And then when you're done, there's a button on it that you push and that will deflate the device. So in terms of this procedure, I do most of mine on an outpatient basis. Like I said, the incision is either on the scrotum or above the penis. We put everything in through that one incision. We do put people to sleep for it. So you're fully asleep. You're not going to feel anything or remember anything. And back to, light activity really the day after surgery. And then it takes a month to 6 weeks for the healing to resolve before you're back. And then we're teaching you how to use the implant. Generally, I would tell you that most insurers are going to cover this. The occasional one I'll see deny it. I had one recently they did, and the patient wrote a appeal letter and they were able to get it covered. So, this is something that we're always going to check. We're not going to take you back to the operating room, for this or many other things without checking and making sure your insurance is going to cover it so that you don't get some big bill for it. Great thing about the AMS and Boston Scientific is that they help us check and for insurance coverage, and they know this market very well, so they help us navigate that process in the folks who get denied, so it can really be helpful for us for getting folks covered. The great thing about these devices is really the people.
It's a general improvement in my whole emotional state, and I wish I'd have been quicker about it and more proactive. That is my one regret about the whole thing, is that I didn't get it done sooner. So don't hesitate.
So what I'd say is it's nice to have patients who are willing to share their experience with it. Yeah, again, it's not always something that people have wanted to talk about much. I do feel like I hear more men say they've talked to their friends about it, or my friend told me they got this, or they did this, or they did that. So I think it's good that it's a little bit more in the zeitgeist right now, and people are talking about it. But we certainly appreciate people like Andy who are willing to put their face, on a video like that, and share their experience with it. So again, very high satisfaction rates, generally going to be covered by insurance. I talked about the durability or reliability of these. Well over 80% of them are still functioning a decade after you put them in. So, again, it used to be we were really spooked out by infections and sort of thought that was going to be the thing leading us to having trouble with it. And now they've done such a good job at impregnating these implants with antibiotics that infection rate has plummeted. And now it's more, well, it's like a car, at some point it's going to stop working. But even in these cars, well over a majority of them are lasting more than a decade. So it's not often that we're having to take one of these out and put a new one in because of something that goes wrong with it. And again, it's the most natural way you're going to get an erection from an implant in terms of both the way it mimics a natural erection and then flaccidity. So the flaccid nature of the penis afterwards. It's going to do absolutely nothing for your sensation, for your orgasm, for your ejaculation. It doesn't impact those or interfere them. So say some of you who might be post-prostate cancer treatment who don't have any ejaculate, this doesn't change that in any way, but it's helping you get rigid. It'll help you stay rigid for as long as you want and essentially whenever you want. It's not to say that a penile implant doesn't have risks. So we mentioned infection. We mentioned mechanical failure, the device breaking or springing a leak. Other things that can happen would be damage to surrounding tissues or organs. There is other stuff, around the penis that could be impacted. And then rarely will we see some of these other things mentioned on here, like migration of the device or inflation issues, but that sometimes can be something that we uncommonly see. Again, the important thing to know from this is that you're not alone. There's more than one of you here watching tonight. So more information you can find here. You can find it on our site. If you forget any of this stuff, look me up on the site and you can find it there. Now, how about stress incontinence? I would say this is going to be a problem that's typically more often helped by surgery. I would say generally, maybe you could think of that as a bad thing. You have to have a procedure to fix something like this. I would counter that by saying, no, these surgeries are really good at what they do. And they're the people that are hugging you, when you're done. Now, that being said, not everything has to be a surgery to help with this. There's behavioral changes kind of mentioned on here. I think those are the things that people figure out themselves. Like, oh, I'm so leaky, I'm just going to not drink a whole lot of fluid. But, who wants to constantly have to limit your fluid for the rest of your life, because you're leaky? In the immediate postoperative period, things like pelvic floor physical therapy can be helpful for what I would say that does is it helps improve the time to recovering your continence, but it doesn't generally make your erectile function, or your continence any better in the long run. So it might get you quicker to drier, but might not make you more dry in the future. Obviously, for those of you who've had prostate cancer, prostate surgery, you have a catheter afterwards. Well, no, that is an option for dealing with the long run. Nobody really wants that, I would say. We do have external condom catheters that sometimes people will use. They slide on like a condom and connect to a bag. So there's nothing inside you, but again, you have a bag on. Certainly pads and diapers are options. I have a lot of people complain about how much that costs. Those are not cheap. So that can be something, that impacts the decision that people make. So what is, the two mainstays of treatment? The Advanced XP male sling system, really great option for men who have a more mild to moderate incontinence. This is done through a small incision under the scrotum and 2 poke holes in the groin. I would generally tell people in my hands, you're going to see probably 80 to 90% improvement in your leakage. I think a lot of people would say that. This study here talking about reduction in pad usage, there's some people who still have a little bit of a hard time completely getting rid of that pad, so while the pad usage may not be 100%, or, reduction in pad usage might not be 100%, I think you probably see people who are drier at a higher percentage than 77%. But some people they've been leaky so long and they're afraid of it so long, it takes them a while to get out using a pad. So how does the sling work? Well, it's essentially a little hammock under the urethra here that helps the sphincter muscle that's left over work a little bit better and support it. And so the great thing about this procedure is it works right away. As soon as the procedure is done, you're better. Generally, we leave a catheter in overnight that comes out the next day, but as soon as that thing comes out, you're better. Again, really high satisfaction rates. 88% of folks would say to their friend, you should get this done. The other option is what's called an artificial urinary sphincter. This is, really what people say is the gold standard of treatment. This is going to be good for guys who have a more significant leakage, or maybe guys who've had a radiation. So I would tell you a sling, at least in my hands, is not something that I will oftentimes do for a guy who has had radiation. The artificial sphincter is really the better option for that, just because of the nature of how an artificial sphincter works. So this is gonna be more similar to the penile implant and how it works. It has a pump, it has a cuff that wraps around the urethra, and then a reservoir balloon that holds fluid in it. And what it does is essentially keeps the urethra pinched off at all times. And so when you're doing physical activity, coughing, laughing, sneezing, it keeps you from leaking. And then when you're ready to go to the bathroom, you pump a little pump, and then it'll open that cuff up, and then you can pee. So here's a description of that here. Here's that pump. Again, kind of about the size of the end 2/3 of your pinky finger, at least my pinky finger. And then it's connected to this cuff. And when you pump this pump, it'll open that cuff up, send the fluid back into this PRB, or pressure regulating balloon, that holds pressure in it. And this, once it sends it back up there, you have about 60 to 90 seconds to empty your bladder. It'll automatically close itself back up. So here's a video demonstration of how, here we go. Here's a video demonstration of how this works. So very similar in that it's 3 components. Pump here, oftentimes kind of have it more in front of the scrotum than it sort of looks on this picture, but you just give a couple squeezes of this and it opens that cuff up, allows you to pee, and then this pressure regulating balloon has a innate pressure to it that exerts on the cuff, and it sends that fluid back into the reservoir, or back into the cuff, excuse me. So similar in that it's also an outpatient procedure, small incision under the scrotum, and then 1 small incision in the groin area. Again, a couple days to back to physical activity, taking it easy. I make people wait 6 weeks before you can activate it or start using it. So you will still be leaky for about 6 weeks. Again, very high satisfaction rates. 85 to 96% of people are saying that I would do this device again. These are some of the happiest patients that I have because of how much it improves their quality of life. They're not stuck at home anymore, just going to church. They can go out with their friends. They can go to the Titans game. They can do the things that they stopped doing because they were afraid of leaking. This, I would say, is also very similar to coverage, for a penile implant. If anything, tend to not have much issues with getting this coverage, or getting this covered. Obviously, I can't speak to every insurance plan, and some are unfortunately worse than others. But this is something that we will always check beforehand. Herschel is a patient advocate, for this. This is not a typical experience. 9 pads to 1. So again, I might tell somebody I'm going to make you 80 to 90% better. Occasionally, I'm Shohei Ohtani and hit a home run, maybe a grand slam and get you 100% dry, but I never promised that to anyone. But I would say almost everyone who walks in the office who can go from 9 pads to 1 is, sign me up. Again, this device is hidden. Nobody's going to see this. You can be at the Y taking your shower, and nobody's going to know that you have this in. None of these devices are visible to the naked eye unless you really wanted to show someone. Much like any surgery, there are risks to it. There are the potential risks of device malfunction, much like the implant. potential risk of infection. For the artificial sphincter, there's a risk of erosion where that cuff can eat a hole in the urethra, and then we have to take it out. And then we have to wait for that to heal up before we can consider doing another one again. But I'd say generally speaking, I mean, even in those guys who've had that happen, they are knocking on the door, hey, when can you put mine back in? Because their quality of life was so much better with it. So again, stress urinary incontinence, common side effect of prostate cancer, lots of different things that we can do it. I would say, fortunately or unfortunately, your best options are surgical. We've got some really good options. These are really great operations that can help you. So, we have the champion program with Boston Scientific. These folks are in some cases available, to share their experiences. And there's a roster of them. If you had questions or wanted to, reach out, we can help you get set up with that. And we can match you, with someone who might similarly match your characteristics and the conditions that you've went through and kind of what your relationship status is. So if you're interested, reach out to me, your urologist, whoever it may be, and we can help arrange that. So I think that's going to be the end here. So, I'd like to see if we can, take some time to answer any questions